Hi, everyone. Welcome to the virtual road trip. I see participants getting on quickly, so we'll give you some time to do so. I'm Pam Brandon with AGE-u-cate Training Institute, and I've got Robert Espinoza here from PHI. So we are glad to have so many people who are joining us today for this very important topic that Robert is going to be talking about in transforming the direct care workforce. So hopefully it is a good day, afternoon or morning, I guess, still for the West Coast people. But I was just asking Robert, who is in New York, what the weather was like there, and it looks like most of us are now enjoying a nice spring, which is nice. No matter, I don't know, many people deal with allergies, I know, during the spring, but it is my favorite time of year. Allergies or no, it's I think this spring we were all ready for it because we so remember what last spring was like. So what a year it's been, right? Hard to put into words what we've all dealt with for the last 14 months. So this is our 16th virtual road trip. We started in January of 2020. And little did we know back then that we would be doing virtual road trips so much. But yes, we are doing them and they've been very successful. So we will continue them. So I am going to go ahead, and the participants are slowing down just a little bit. So again, my name is Pam Brandon with AGE-u-cate Training Institute. I am the president, and welcome everyone to the road trip today. And we're traveling to New York City with Robert Espinoza from PHI. If you are new to the webinar and have not connected with us before, just a little bit about AGE-u-cate Training Institute, or ATI for short. We're a global company dedicated to delivering effective and innovative dementia and aging care training for professional and family caregivers. Our flagship program, which launched in 2015, was Dementia Live, which is a transformational simulation experience. Our other programs that are under our family of programs we call our Compassionate Touch, our Skilled Touch program, Flashback, our Life Engagement program. We partner with Ageless Grace, which is our brain and body fitness program, and our cutting edge Reading to Connect program, which is the brainchild of Susan Ostrowski. We're very excited about that. And very timely that we're going to be talking about workforce, but we worked very hard during COVID to develop our Reveal Aging training initiative, and are now focused on workforce training in the area of quality of life training. So Reveal Aging initiative is our newest program, and we're very excited. So we encourage you to connect with us. Peek on our website and see what we're doing these days, and we'd love to talk to you. So with that, I am going to move right into introducing Robert. We are so happy to have you here. Robert, again, is from New York, Brooklyn in particular. He is the Vice President of Policy at PHI. He oversees its national policy advocacy, research, and public education division in support of the direct care workforce. He is on the board of directors of the American Society on Aging and the National Academy of Social Insurance. In 2020, he was selected for the first ever Care 100 list of the most innovative people in the people working to reimagine how we care in America today. I think that's amazing. I'd love to hear more about it. And he is one of the Next Avenue's 2020 influencers on aging. He's a recognized speaker. That will be no surprise after you hear him. He's awesome. Very knowledgeable in his field, but I have to say that I think the initial connection I had when I first heard you, Robert, was that you came into this space from personal experience, and that's how I came into this space. And so behind your knowledge and your expertise is this passion and heart for what you do that shows in the work that you do and how you present. So, you know, I can't wait to hear what you have to share with us. And so, Robert, take it away. You have lots to talk about, and I encourage all the participants there to go ahead and chat questions. We'll let Robert present, and then we'll have our Q&A time afterwards. So, Robert, welcome. We're delighted to have you.
Thank you, Pam, and thank you to the AGE-u-cate Training Institute for inviting me to speak on the direct care workforce. I'm going to take just a few minutes to share my screen because I will be using a PowerPoint. So just bear with me. So as Pam mentioned, my name is Robert Espinoza, and I'm the Vice President of Policy at PHI. We are a national organization that's focused on strengthening the direct care workforce, specifically with the philosophy that caring, committed relationships between direct care workers and their clients are at the heart of quality care. And those relationships work best when direct care workers receive high quality training, living wages, and respect for the central role they play. Any of us who have engaged a direct care worker or have accessed this type of support know how valuable this type of support is. And I think the point of this conversation is to give people a sense of what are the challenges that this workforce is facing and what can we do regardless of whatever field we work in to really improve their jobs and improve supports for all of us. A quick note on direct care workers. By definition, direct care workers are workers who support older adults and people with disabilities in a variety of settings. They work in our private homes, they work in nursing homes, and they work in a vast array of residential care settings like assisted living and other examples. Their titles do vary by occupation, they vary by state, and they vary by providers. So you'll hear them called, a variety of names depending on where you live and where you work or receive care. Our research shows that there are about 4.6 million home care workers and nursing assistants who support these older adults and people with disabilities around the country. And because of the growing demand on these workers, largely spurred by growing numbers of older adults and the fact that all of us are living longer, or I should say most of us are living longer, the demand for direct care is also booming. So we estimate that between 2018 and 2028, the long-term care sector will need to fill about 8.2 million job openings in direct care. These are new jobs that are being created because of growing demand, but a lot of them are job openings that are happening because workers are leaving this field for other sectors, or they're retiring or exiting the labor force. This past year of research, the direct care workforce is now larger than any other single occupation in the US, just to give us a sense of the magnitude of this workforce. Direct care workers, there are various segments that are included within this workforce. Many of you on this call know this, but home care workers include personal care aides and home health aides who support people in their homes. The difference between personal care aides and home health aides is that personal care aides do not handle the types of clinical tasks that home health aides manage. And so in that sense, their scope of work is very different in that regard. But they are also the largest part of the home care workforce. So we're seeing more and more personal care aides. Nursing assistants in nursing homes during COVID have really been in the news because of obviously the impact that COVID-19 had on nursing homes. And they do all the work that home health aides do, but they're focused in nursing homes. A lot of direct care workers work in residential care homes, in assisted living communities, continuing care retirement communities, and many others. And then a lot of direct care workers work in hospitals, employment services, and other services supporting those types of needs. Additionally, we also look at independent providers, which are workers that are hired directly by consumers through publicly funded programs like consumer-directed programs. They are family caregivers in many ways who are being paid by the state to offer this level of support. And direct support professionals are workers who support people with intellectual and developmental disabilities, and they are typically captured within the home care workforce. But unfortunately, because there is no federal classification for direct support professionals, we actually don't know kind of the vast numbers, the precise data on these workers. There are generally four trends that are igniting demand for direct care workers. One is that we are seeing growing numbers of older adults in this country. This is probably a stat you've seen before, but between 2015 and 2050, the number of people aged 65 and older will more than double from 47.8 million to 88 million. And that's obviously creating enormous possibilities and pressures on our country. There is increased longevity, so people are living longer these days. And with increased kind of age is the idea that there are also increased functional limitations and daily support needs. Increased rates of dementia is another example. Most people prefer to age in their homes and in their communities, and increasingly in the last few decades, I think the trend has been to drive more support towards home and community-based services. And I think we're seeing, a growing number of home care workers and the demand in that sense. And also new family norms. So it's become more typical for children to leave the household or their hometowns and city and states. Also growing numbers of singletons, people without children as well, and a growing acceptance for paid support. And so this is obviously placing demand on direct care workers. The vast majority of direct care workers are women, about 87%. 1 in 4 direct care workers is an immigrant. About 59% of workers are people of color, and the median age is about 43, though it should be stated that 1 in 4 direct care workers is aged 55 and older. So as our country ages, so does our workforce, right? And what are the implications of creating age-friendly supports for workers as well, right? Workers face a number of challenges, and I'm going to cover some of the primary challenges that we see through our research and through our experience. Primary is the low compensation that direct care workers earn. The median hourly wage for direct care workers is a little over $12. Many direct care workers are relegated to part-time work, either by the economy or by their employers. About 31% work part-time. This leads to median personal earnings of around $20,000. And if you've ever done the math of how do you take, $12 an hour, 40 hours of work and spread it across all the expenses, it quickly spends down, right? And I think this is the challenge that many low-wage workers face in this country. 45% of direct care workers live in or near poverty, and it's impossible for workers in many cases to make ends meet or to stay in this field. This is a graphic that tries to show in rough terms how poverty affects health and how it affects the choices that workers make. If you take a rough estimate of, say, $10 an hour at this point for 40 hours times 4 weeks, you'll net pay about $1,200 net pay in that month. When you break out the monthly expenses and try to cover the variety of needs, you'll need to cover housing, utilities, food, transportation. Many low-wage workers have high debt repayment and credit cards, and clothing, entertainment, etc. And of course, if you have children, that multiplies expenses in many areas. The National Low Income Housing Coalition regularly looks at what does it take to afford a modest apartment in each state. And what you can see from this graphic is that there are very few states in this country where you can earn $15 or less and actually afford a modest apartment in their states. And so already you can see what it does for housing instability. Also, poverty and poor health are linked, and you see that with high rates of poverty, there are decreased life expectancy, lifelong illness, poor nutrition, and the link book goes both ways. Poor health also hurts employment chances and the ability for people to obtain stable jobs. So this is a devastating impact on people's health and on their employment. Workers themselves often have a lot of thought, and I love this quote from Culex Wibinell in Georgia, who says, "Many CNAs do not get paid enough. You have a lot of responsibility taking care of members. When you are not earning enough money to make ends meet, many people leave to find better pay." And that's well said and well documented in our research. The training landscape for these workers is also not strong enough. There are insufficient training standards. There are no federal training requirements for personal care aides, which, as I mentioned, is the largest segment of the home care workforce, or direct support professionals. There's also a lack of specialty training topics to address issues like dementia care is one example, or populations like LGBT elders, or culturally and linguistically competent training to address the wide array of cultures and experiences that we see in these workers and among consumers. Our experience in the field also shows that most training programs are didactic in nature and they don't kind of classroom style, right? And they don't really account for the methodologies that would support adult learner-centered learning and other learning styles, people with different learning and accessibility issues. And there are a few opportunities for advancement in this sector where workers could be better integrated and optimized in the care team, but where they could also earn more money and see this job as a career. Also potentially support cost outcomes, which are really important for employers and for the economy, for the broader public system. All over the country, we are seeing employers struggling to recruit and retain workers, and this is a major challenge driven largely by a high turnover rate. The latest data on it shows that the turnover rate for home care workers, it can be at around 64%, about 99% for nursing home staff, and many workers often leave within the first 90 days. Also, in many states where low-wage workers have options to work in other industries, like retail or fast food that might be offering jobs with modestly higher wages, or less demanding jobs, right? You're seeing that long-term care employers simply cannot compete with retail or fast food. I've traveled around the country and was doing this quite a bit before COVID. And one of my kind of startling experiences were seeing the advertisements for fast food companies or for companies like Macy's for low-wage workers, right? And you would see that there were starting bonuses and that their starting hourly wage and other benefits, including kind of stable schedules, was much stronger and much better than what you would see in those same states for home care in particular. And so I think that really tells us about how much we value or don't value direct care in this country. These challenges, by the way, are actually much harder if you live in rural parts of the country. This is two graphs that were taken from a landscape analysis that we did in Minnesota a few years ago, where we looked at the care gap in both rural areas and non-rural areas, or urban and suburban areas, right? And the care gap, as we defined it, was the gap between working age women 20 to 64 and people aged 65 and older. You might roughly describe as the typical demographic for these workers versus the typical consumer for these services, right? And what you see is that the care gap in non-rural areas and urban areas will start to grow in the early 2030s. But in rural areas, that gap has already started to grow, and it will explode in the decades ahead. I mean, what this tells us is that if you're a consumer who needs paid services and a worker to deliver those services in rural areas, unless the state intervenes, we're going to have major challenges in finding good workers, much less qualified and trained workers, right? We do know that the diversity of consumers has grown over the last few years, and it's the same with workers. And yet we often see a lack of cultural and linguistic competence in both the delivery of services and also workforce interventions. We know from research that there are disparities in the ways in which people of color and immigrants and people with limited English proficiency can access these services. And yet what we know is that too often, both the services that are being delivered and the workforce interventions that are being implemented don't take into account those differences. And so what we don't know is the extent to which people are benefiting equally in either regard. And that can really hurt a large percentage of people who need these services and who need these jobs. One of the biggest challenges we faced during COVID was knowing the extent to which there were available workers in many states whenever a hotspot emerged. So when a city or a state or a neighborhood exploded with COVID cases or COVID deaths and complications, one of the biggest questions we received were, are there available workers nearby or in nearby states who might be able to come in and help meet that demand? And the answer is we don't know. In terms of traveling across states, that's just the structural challenge. States' training requirements vary, and so a worker cannot travel from one state to a neighboring state unless they've been trained and certified in those states, right? And similar, which is in opposition to how doctors, for example, were flying from one state to the next, or nurses. But we also don't have enough data to know whether there were workers in nearby towns or cities who might be able to come within a state. And this is a major structural challenge. There's little systematic workforce data on this workforce that would measure areas like volume, how many part-time and full-time workers, are they in my state or in different parts of my state? Stability, which would look at turnover and vacancy rates, and compensation, how much are people making, et cetera. And if we had this data, we would obviously be better prepared to navigate a health crisis, but we would also be better able to kind of identify what a state needs in terms of resources, right, to meet growing demand over the next few years and decades. There is no federal occupation code or classification for direct support professionals. So we have little data on this workforce and the level of support that people with IDD need, and little data to answer where our workforce needs the greatest. That's both a question around workers, but it's also around the methodology about being able to figure out how do we qualify workforce need or just LTSS need in general. All of these issues don't have enough attention in our perspective. There's little awareness about this workforce crisis and much less the solutions that are needed to really support workers and consumers. My experience has been, as Pam mentioned at the very beginning, that many people who are influential in this sector often become invested because they themselves as individuals have been affected. They themselves need supports and services, or a family member or a friend needs these supports and services. And when they turn to the government or their local community for support, they realize that it's scattered, it's dysfunctional, it's under-resourced, and it's just not thoughtful about how to guide people step by step, depending on what you need. And there's little money, public funding support, so you're often required to spend down your own income and assets to qualify for public support. And yet, public awareness would really drive in the ideal and tap into the kinds of personal experiences we're having to really kind of move the needle, so to speak. There are very few resource public education or advocacy initiatives that would bring to light all of these issues I'm discussing. And although the media coverage really bloomed in the last 2 years, I would say, especially with COVID, on this workforce, it's nowhere near where it needs to be. And I can talk more in depth later about what are some of the issues that need to be better covered. All of these challenges, by the way, are under the umbrella and under the overarching challenge of inadequate public funding and reimbursement. Long-term care is expensive and it's difficult to predict. It often requires people to exhaust their savings first to pay, because Medicaid is really a program that's really only for poor and low-income people. And the restrictions are growing and state budgets are increasingly strapped, right? In many states, the largest item for those budgets is labor cost. And so obviously this is an issue that needs to be addressed. And many providers, from nursing homes to home care agencies and others, will tell you that they don't receive anywhere near the reimbursement rate they need to provide proper services and support, much less to improve direct care jobs. So until we reimagine and boost funding and financing for this sector and workforce, it's difficult for us to imagine how we'll make progress in this regard. The COVID-19 crisis really amplified and reinforced many of these challenges. Some of the key issues that we've been seeing, especially in the very beginning, were limited access to PPE and other supplies like gowns and thermometers and other needs. We saw that workers were inadequately compensated. Many did not have access to health coverage or paid leave if they got sick, or their family members got sick, or childcare. One study looked at the direct care workforce in the first few months and found that it contracted by 280,000 workers in the first few months. And this is devastating, right? Workers are being forced to make that impossible choice of, do I go to work, and support my client, but risk getting sick without paid sick leave and without, at $12 an hour, or do I stay home and collapse financially? And it's an impossible choice that an essential worker should not have to make. Many of the measures that were implemented were temporary in nature, from hazard pay to relaxed training requirements to childcare supports in certain cities and towns. And the debate really now has been about, to what extent should we make them long-term? And it really reinforced the idea that health equity and the health realities of all of us as individuals and our families are directly linked to the health equity and supports that workers themselves face, right? And so we should think of ourselves as entwined, as what affects one affects all of us. Erica Honan is a home care provider and an emergency response team provider in San Francisco, and she said this: I think isolation in general is a challenge for caregivers, but with the risk of COVID added, it has really been very taxing. I'd say that's the hardest part of the job for me. We've been interviewing workers for the last year or so on COVID, and some of the most dramatic and kind of profound stories have been of workers who have stayed away from their families in many ways because they don't want to get either their families or their clients sick. And many people who really had no choice financially to go to work and to risk their lives and the lives of their families. So they are heroes in many ways, but we need to move the hero discourse to a conversation of how do we value and recognize and pay these workers appropriately. So what should we do regardless of what field we're in? I'm going to move the last 15 or so minutes of my presentation to this conversation. I would say from a big picture perspective, what does this mean for us? I would say regardless of what field you're in or what role you're playing, we should acknowledge a few realities. One is that our country is in a time of growing and changing demographics that is shaping how we deliver care and how this workforce is supported. Those demographics are across race, across ethnicity, across country of origin. I mentioned they're across age as people live longer and growing numbers of older adults, around ability and disability, around access issues, and also around complex conditions, right? We are seeing growing rates of dementia and growing rates of need that really shape how we think about all of our populations and workers, and so many other areas that I'm sure people could speak to as well. I would say the future of healthcare in general is team-based and interdisciplinary. Any of us who have never ever navigated the healthcare system and long-term care system too often sees the opposite, which is that we have multiple specialists and doctors and providers who in many ways don't talk to each other, and we're kind of required to facilitate that system in many ways kind of on our own, and it creates all these dysfunctions. But if we really are to optimize healthcare and long-term care for both workers and consumers, we need to think about an interdisciplinary approach that really systematizes and connects all those dots for the future. The third is an area that I think really emerged out of the disability rights movement, which is that all of us have non-medical needs and broader aspirations. We want more than just diagnoses and medications, surgeries and medical treatments, right? We want to be understood as for our needs and our aspirations and our social supports. And all of us are part of complex systems and larger communities. And perhaps there's no more profound example than when we think about immigrants in long-term care, where so many immigrants are actually navigating complex immigration-based realities, whether it's legal realities or financial and social. And for us to support this really critical part of the long-term and healthcare system means understanding their needs as immigrants, not just their needs as workers or as people in general. And I think these four dimensions are really shaping health and long-term care. Last November, PHI introduced a new framework for employers and for policymakers on what it means to improve job quality in the sector. It's called the 5 Pillars of Direct Care Job Quality. The 5 pillars generally are quality training, fair compensation, quality supervision and support, respect and recognition, and real opportunity. And I'll cover these briefly, but the full framework is available on our website at phinational.org. There are 29 elements across these 5 pillars that we think if they were fully adopted, funded, and kind of executed across practice and policy and research, they would probably transform the direct care workforce in a way that would affect all of us. Quality training includes elements like making sure it's accessible, affordable, and relevant to the job, making sure that training for workers covers the range of relational and technical skills, that it's competency-based. In other words, it's based on an agreed upon set of competencies that as skilled experts we believe in, that the approach is adult learner and centered, and that there's opportunities for hands-on learning. We cannot become direct care workers by just taking classes online and learning something over 30 minutes, right? Workers need to be able to practice hands-on learning. That these programs are accounting for cultural, linguistic, and learning differences, and that there's some form of documentation and verification process where if you've completed a program and are certified, that employers would know that and workers would know that, so they can kind of travel more easily across settings. Those jobs should be compensated based on a living wage, which is a formula based on cost of living in your area. And that's a base wage. So if you're making you should make at least that living wage, but ideally more. Workers should have access to full-time hours, addressing that part-time inequity that so many workers are facing. They should also have consistent scheduling, and when there are changes in their schedules, they should be notified. And access to benefit plans either through their employers or through their unions if they're unionized. A lot of grief support and bereavement leave is necessary, and we've seen that through COVID-19, where workers are often seeing, their clients, their residents, and their own family members pass away, and that can be devastating. Financial support and asset development programs, so that even at a living wage, you're able to save for your retirement and save for the kinds of needs you have. And access to pay increases through merit, longevity, or other bases is essential. Too often workers leave these jobs because of poor supervision, and too often supervisors are promoted or hired into those roles without proper training. And we think if we're going to improve these jobs, supervisors should present a clear presentation of job requirements, responsibilities, workflows, and reporting structures. Supervisors should be accessible, consistent, and supportive. They should have access to PPE and other supplies to ensure safety. And they should have access to peer mentors and peer support networks so that workers are able to learn from each other and that they can teach each other as well, right? And real connection to organizations in their communities that can address barriers to lives and employment, like childcare supports or transportation supports, as two clear examples. We need to respect and recognize the job. And really, as employers, as agencies, workers should be reflected in the mission, the values, and the business plans. Diversity, equity, and inclusion really should be formalized in an organization's practices. We should be offering consistent feedback, not just when people are being evaluated in their annual performance reviews. And there should be opportunities for workers to influence the decisions of organizations and clear communications about any changes that are affecting workers. This, by the way, was an issue that came up again during COVID in the early months, where workers were being told just overnight about any change that was being made about COVID, and they weren't having a chance really to inform it based on what they were learning in the field, or really to learn it and embody it before the change became practice. And that can really cause a disruption in their day-to-day work. Making sure that direct care workers are empowered to participate in care planning and coordination, and that other staff in an agency are also trained to value the input of workers and skills, so that we're really seeing respect going in all directions. And the final pillar is real opportunity. How do we create kind of continuous learning, not just entry-level learning, to really build skills, maybe on infection control and prevention as a key example during COVID-19. Opportunities for promotion into advanced roles like peer mentors or dementia care specialists that are both within the scope of practice, so to speak, so that it doesn't require like a change in law in terms of, and it doesn't impede on like the scope of practice of nurses, for example. But maybe also opportunities to think about how can workers go beyond direct care to advance in their own ways. Commitment to cross-training workers and promoting from within first when those opportunities emerge, and then connections to any external training and job development programs. And we're seeing an investment in that regard. In January of this year, we released the signature report on the direct care workforce called Caring for the Future, which is more for kind of the policy and research audience that might be joining us today. It's also important, I think, for industry leaders who are interested in that sector. But what this report did was really offer kind of an in-depth review of these workers with the latest data, with worker stories, with analyses of all the issues that I've been discussing and more. And most importantly, we offered recommendations across 8 key areas, including how do we improve long-term care financing by creating a stronger public financing approach, maybe a social insurance program at the federal or at the state level. How do we increase reimbursement rates for employers across the spectrum? And how do we protect and strengthen Medicaid, recognizing that it's still the primary funding vehicle for this sector and for these jobs? Cameron Hayes is a worker in Madison, Wisconsin, and he said, there's too much work to get done and not enough people doing the work. And I know that a lot of that has to do with pay. And he's right, in many studies, workers often cite low wages and low compensation as the primary driver for why they leave these jobs. So we really argue for increased compensation, again, a living wage and full-time schedules. We should strengthen the social safety net, like paid leave, social insurance programs, childcare, et cetera, and improve access to workplace benefits. And finally, we really should be evaluating as researchers and as policymakers the unintended impact of wage increase measures. So if we raise the minimum wage, for example, in certain states, what impact does that have on a sector that's so reliant on Medicaid, where employers might be compelled to decrease service hours and it might affect consumers, right? We just need more data and research in that regard. We need stronger training standards and delivery systems, perhaps a national standard for all direct care core competencies that all direct care workers must meet, and incentives to make sure that employers are meeting that. We really need to overhaul the training curricula that exists out there, whether it comes from the private sector or the public sector, strengthen the training infrastructure so that all the training programs out there have enough money to really embody the latest and best practices, and of course, more money for enforcement and for the training delivery. We need a stronger pipeline of workers into this sector so that when nursing home workers run out of workers, so to speak, because of COVID-19 or other reasons, but there is a pipeline so that they can draw on workers who might be able to fill that demand, but also those 8.2 million jobs I mentioned by 2018 and the years ahead. We need additional skill building at the entry level, and we need to better integrate workers onto the care team, maybe through advanced roles and through training, and really develop rungs in the career ladder where workers are able to ascend that ladder within their so-called scope of practice or beyond if that's their interest. We need better data collection systems at the state and federal level, new classification codes, not just for direct support professionals, but perhaps a revision of all of the industry and occupational codes. My research team, and I think a lot of researchers out in the sector would say, we could express a lot of ways in which the codes that are currently being used are inadequate and they need modernizing. And then of course, quality measures so that we're also measuring the extent to which both jobs and care are being improved through research, practice, and policy. Workers are experts, as I've seen in this quote, and we should establish mechanisms for them to inform, maybe a statewide work group where states fund workers and payers and providers to come together to think about the recommendations. Maybe we need divisions of paid care at the local, city, and federal level that would be responsible for supporting workers with their rights, responsibilities, and needs, and certainly more workers in key advisory roles in our agencies and in our sectors. We need strategies to address systemic gender and racial inequities, maybe better data on disparities, or just an evidence base on interventions that are doing this work, and of course, broad support for immigrants in this sector. We need to shift the narrative through stronger public education campaigns. We need to build a communications capacity of nonprofits, of employers, of policy thinkers to really advocate in the best way possible for these jobs. And we need more storytelling projects, largely of workers, but also of high road employers who are doing the right thing, or of consumers who know what it means to have a strong and highly trained worker. At the federal level, we've seen an investment in many ways. The American Rescue Plan that was enacted in January of this year offered about $11 trillion for COVID relief and recovery. And it's up to states really to argue for implements like better payment rates, hazard overtime and shift differential pay, recruitment and retention, et cetera. And we'll be producing a fact sheet and a bunch of other resources to help people at the state level argue for this money. The American Jobs Plan has been introduced, which would inject $2 trillion in building the infrastructure, of about $400 billion for expanding HCBS and raising wages for caregivers. But there are also other measures beyond the $400 billion that could support these workers through sector-based training programs, career pathway programs, community college partnerships, and more. And again, we'll be offering some analysis for people to be advocating for that at the federal and at the state level. This is an article we published a few weeks ago that makes an argument for all the ways in which the American Jobs Plan can really support workers. There's also the US Citizenship Act of 2021, which would provide a path to legal residence and citizenship for as many as 11 million, as well as targeted supports for essential workers, which would include direct care workers. And again, we'll be offering analysis, and we're looking at partnering with a few organizations in this regard. And the reintroduction of the Direct Care Opportunity Act will hopefully happen soon, which would strengthen direct care recruitment, retention, and advancement interventions, and more money for that work and more evaluation money. and we'll be offering some resources on that. And there's the potential of an act that would fund and expand home and community-based services. There's a draft bill that's available to the public, and we believe that a critical part of that kind of access and supports for grants should be about workforce development for compensation, training, advanced roles, recruitment, retention, and more. And we'll again be offering fact sheets with key ideas. I want to end with this quote that I love from Marisol Rivera from Cooperative Home Care Associates in the Bronx. She's a home care worker and advanced worker in the Bronx, and she argues, I think the role of the home health aide should be considered just as important as any other healthcare role. And I end with this quote because so often the major challenge that these workers face is about misrepresentations and a lack of valuing. There's a misrepresentation that this work is low skilled or unskilled work, which is absolutely not. It requires quite a bit of skill and training and support, including emotional labor. And how do we make sure that these jobs are properly addressed in that regard? But also, I think there's a sense that these workers aren't as valuable as doctors or nurses, and they're treated as such sometimes within the healthcare system, or by any of us who work with them. And the truth is, if we valued and saw these workers as critical as doctors and as nurses, and we embedded them kind of in an optimized way in the interdisciplinary care team, I believe that we would just elevate the role of these workers as long as they were properly recognized, paid, and supported in so many ways. I want to just emphasize that all of this information, the reports, the fact sheets, and so much data is available on our website at phinational.org. You can also join us on Facebook, Twitter, and LinkedIn at PHI National. You can subscribe to news updates. You can download state-by-state data, share resources. We also have a range of publications and fact sheets that you're welcome to share with your colleagues or just peruse at your own leisure. And certainly reach out to us if you see topics that are understudied. We run the National Direct Care Workforce Resource Center, which was seeded with federal funding, I believe in 2003, to really provide resources on the wide range of publications that are being published on this workforce, not just by PHI, but by others in the field. And we've run the Direct Care Worker Story Project, where we interview workers from around the country to tell their stories in their own words and feature their photographs and their ideas. Again, please follow us on social media, and you're welcome to email me or follow me on Twitter based on this information. I'm going to stop the presentation and open it up to questions or anything that's been posed on this chat as well. Was I able to pause to stop the session?
Yes.
Okay.
Yep. Yeah, that was great, Robert. So much to think about. You know, there's lots of stakeholders that are listening to you right now. And so, you know, it was 25 years ago, over 25 years ago, when I was a family caregiver, seeing these things way back then, right? We have been talking about these issues for many, many, many years. Mm-hmm. COVID brought much of this to light. I'm going to go through this panelist list so that you can concentrate on, you know, answering questions, but how quickly do you think some of these things are going to get passed? You know, I know you don't have a crystal ball, and, you know, there's lots of important things at the federal level that will help us because we are in a crisis mode here. And all of us should be very, very concerned, no matter what end of the spectrum we are in. But what is your take on, you know, things getting started?
Mm-hmm. Yeah, it's a great question. And, you know, I think so much of the attention at the national level is often on wages. And wages is obviously a critical aspect of improving these jobs. And it's dependent often on an increase in funding at the federal and state level, right? And we know that we're in a time of strapped resources, and so it can feel like kind of a much harder kind of option. Biden's American Jobs Plan will ideally invest about $400 billion in improving wages, but it's a sector that's so large and it's across 10 years, across many states, that it's hard to imagine that unless we think about structural changes, that we'll be able to sustain those wage increases. In terms of what's possible and like realistic, I think it's important for us to think about the wide range of policy options that we can pursue, including those that are more affordable and low-hanging fruit, so to speak, right? And PHI has been advising and working in various states around the country for decades. But in the last few years, we've been working in Michigan, in North Carolina, and New Mexico with coalitions in those states to imagine those kinds of policy options. And I think those have a lot of potential and can be moved right now. Some of those policy options include, working with your state to establish a state work group on direct care workers that can bring together a variety of stakeholders, from providers to workers to consumers and many others, to sit down and talk about the problem and then develop a multi-year roadmap for achieving those changes. We've seen at least 16 roadmaps in that regard all around the country. And so this is something that states can ask for in their budgets right now. And you can develop that work group and begin developing those roadmaps. You can also look at options. People are exploring creating matching service registries, which are these websites, these online portals where consumers can find workers and workers can find consumers based on their needs, their preferences, and their availability. There are, this was a trend for a while, and there used to be around 20 matching service registries around the country, but they've since decreased. And I think this is a great opportunity for advocates and state leaders to develop and fund matching service registries, that websites that would really help people identify each other, but also could better collect data on these workers and so on. You can also commission new reports, better data on any of these workers. We can look at, how do we strengthen training requirements at the federal and at the state level? There are opportunities to convince both our state and federal lawmakers to develop training programs on dementia care, on social isolation and loneliness, on LGBT cultural competence. And certainly, I think anything that professionalizes and standardizes these jobs through certification, through training, through advanced roles would make a big difference. I just think our imagination needs to be bigger and think about the full range of options. Yep.
Yeah, absolutely. I think, we learned to be innovative in this last year, and we can't necessarily wait for everything to come from the top. We've got to do what we can at our local levels.
Yep.
Start conversations, do more with collaborating with other organizations, and and get going, because we have no other choice at this point but to to do that, right? I want to address some of these questions. Julie asked us, she said, I notice elements of these 5 pillars that can be started now. What do you think are the 3 most impactful things that employers could do right now to strengthen direct care jobs? And you addressed some of that, but
Yeah, absolutely. I mean, I think it really depends on it depends on the provider and the agency, right? Whatever issues that are of more interest or where people are based. I mean, I would say that certainly looking at your organizational values and your mission statements and your guiding documents, whatever the framework is, and really looking at it through a lens of how does this support workers and other staff in our agency. That's a critical first step to make sure that direct care workers are oriented in that regard. The second is that we've heard a lot of success about the importance of peer mentor programs, and making sure that workers can support other workers, especially when a worker is new to the job. They often have a lot of questions about how to do something on the job. And when an employer is able to develop a peer mentor program and maybe a peer mentor advanced role, to really be there for those kinds of on-the-job questions, I mean, that can have a major difference in how people are supported. And the final thing I'll say is that I think there's a lot of success that we've seen when employers have partnered with community-based organizations who are able to do things that they cannot do, like support with transportation or support with accessing their public benefits if that's what they need, right? And so, or community colleges and training programs, right? The more that you have that a worker is, the more easy that the way in which a worker can more easily access those supports in their communities through their employer because it's been vetted and it's trusted, et cetera, I think they're more likely to succeed on the job. I would focus on this right now. Yeah.
Yeah, and definitely, shows that the employer is invested in them and, values them. Is certainly, we all need to feel that in our jobs, no matter what. And I think for far too long, we have not elevated the work that they really do, which is run the businesses, the real core of the businesses. Brycey said we are already experiencing the shortage of in-home care workers when trying to create in-home plans of care. The providers with whom we're contracted are telling us they do not have the workers to fulfill these care plans. What can we do as a care coordination agency to help?
Oh, that's a big one. It depends. I think that problem. The answers are at multiple levels, and certainly my focus is more on the policy systemic level. I would say, and to the extent that your agency is working or advocating for, government reforms or policy funding, et cetera. I mean, I think there are a number of issues that need to be addressed there. I mean, one is states, I think, need to do a better job of assessing the workforce shortage across their states and the many drivers for that workforce shortage, because employers then see the consequences of not having enough workers. They're not able to find workers, they're not able to recruit more workers or retain them, right? And so I think that a good part would be for the state to commission an analysis on all of the driving factors for the workforce shortage, and to come up with recommendations that can be implemented at the government level, but also at the local and provider level. And sort of what does that look like, right? Because the reasons I think are many, and it's important. I didn't get a sense of what type of area they're based in, but the solutions are going to vary if you're in an urban setting versus a rural area. And I think that's a major problem. I mean, for us, the driving factor for turnover and why it makes it so hard to recruit new workers is that the jobs just can't compete. And so I think a big question here is, what does a job look like, both at the agency of the person who's asking this question, but the norm in that state? Are they paying enough? What is the reputation of that employer in the community among workers? How, are there sufficient training opportunities? All of those questions that go to both the quality of the job and also the branding and reputation of the agency are going to make a big difference as to whether or not they can attract workers. But I think the question, which is much harder, which is, the agency that isn't able to find workers to funnel into this agency, that's a systemic issue, and I think that it needs to be handled at the state level. Yeah.
We have to open those, we had an initiative, at least at state levels, that we're talking about these jobs, letting people know what these jobs are. I mean, it's a difficult job to be a care worker. It also comes with many benefits. I mean, if you are a compassionate, caring person and you are trained well and you're paid well, it is a job with, great satisfaction.
Yeah.
I think there's just, we don't have that conversation going enough right now.
Yeah.
I think that can help tremendously and should be part of bigger plans. And, for us to let people know, unless you've been in this space, you don't know about it. So you're going to go and get that job in fast food but you may be made for this kind of work. And it can be very satisfying.
Mm-hmm.
Okay, Mark says, and this is a technology question here. How many years do you expect it will take until home care robotics can help this burden? I wonder if a robot can be taught to assist, say, a patient with dementia. I think they're doing a lot of this in Japan.
Yeah.
I don't have a lot of knowledge in this. What can you share?
Yeah, it's a great question. It's one we hear quite often. When we think about what it would, first of all, when we think about robots, we think about, these kind of lifelike, artificial intelligence driven robots who are able to function almost as humans in some regard, right? if that's the vision that we have of robots. There's quite a bit of steps that we'll need to take to get to that, if we get to that, from both the scientific breakthrough aspect, which I know we're making progress in that regard, to the widespread application of it, which would require a whole other type of investment, to like access and funding and reimbursement barriers that I think we often face in healthcare and long-term care, where we'll see this really amazing tech innovation, but a very small slice of consumers or agencies can afford it. And in Medicaid funded space, it's simply not reimbursed, right? So I don't know how far away we are from a space where anybody could afford a robot that actually works, or if it will ever work. I think the more interesting question here is about artificial intelligence and the use of technology in direct care. And here we're already seeing some important steps forward. One is that I think, that especially in rural areas, we need to think about what are the aspects of home care, of delivering home care in rural areas that can be automated, that wouldn't displace workers, but that would make it easier for both consumers and the services and the agencies to basically deliver necessary care. Like, are there ways for medication management, for example, that could be handled through technology? Certainly lifting, maybe, I'm not sure exactly what that would take, but there will always be so many tasks that home care workers will perform that probably technology won't take on and shouldn't take on, right? Because there's a level of emotional support and problem solving that often workers provide. So I think being able to parse out what are the skills and competencies that might reduce the burden on agencies and workers, and that consumers will still feel comfortable about I think that's a big step to addressing it. The final point I'll say on this is that I think there are issues around privacy, and that's an issue that both consumers and workers will bring up, which is the more we digitize and automate supports in the home, it raises questions about autonomy and being monitored and privacy. And any of us who have had that conversation about putting up a camera, for example, in a parent's home, et cetera, that is a complicated conversation, and it raises a lot of questions about privacy, about rights, and all of that. So we'll need to manage that debate and the ethics of it as well. Yeah.
A lot of complex issues, lots of questions with not a whole lot of answers, and at the big picture. But it's conversations like these and the work that you've done, that PHI has done. I highly recommend that everyone who has not looked at these reports that PHI has created, and we will be sending out a recording of this was an excellent presentation, that you take a good look at what they have done, what they are doing, and the important work of advocacy, that, again, as stakeholders, we're all invested in this at some level. And I'm one of those boomers marching toward the need for care, and hopefully down the road, but our oldest baby boomers are there now. So we are at a pivotal time when I think we're going to see much done, and I always want to think the glass is half full. So it's our time for all of us to work together and to do more to get some solutions in place and improve the care in this country that our older adults deserve. So thank you so much, Robert, and for all of our participants. I think we could probably talk for hours on this, but again, the resources that you provided are very valuable to all of us. So thank you so much for your time. And before I go, I just want to remind everyone that next month, our May 19th is our next speaker, and we're going to be welcoming and going back to the Midwest to hear Mike Logan. He is the CEO of Michigan Masonic Home, and his topic is gentle leadership through traumatic times. And I think hearing his story and being able to share what many of you have gone through, and be able to talk through that is going to be very inspiring for us as well. So again, Robert, thank you, and thank all of you for participating today, and we look forward to seeing you next month. So thank you, and have a good rest of the week. Bye.